Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN. Healthy you, healthy nation, healthy world. I am Nancy Valentine, PhD and registered nurse, and this show is dedicated to you, the healthcare consumer. And today our topic is on plastic surgery. Now, when most people hear about plastic surgery, they're thinking about facelifts or some way they're going to be cosmetically more beautiful. Like, who doesn't think about that? But today we're going to really look at the other side of plastic surgery, which is referred to as reconstructive surgery. And therefore, the title of our show today is Plastic Surgery, Not Just Another Pretty Face. And we have a marvelous guest with us today, Dr. David Lowe from the University of Pennsylvania. And I'd like to introduce you to Dr. Lowe, who has an outstanding background. He is professor of surgery in the Division of Plastic Surgery at the Perelman School of Medicine at the University of Pennsylvania. He is the attending surgeon there as well for the Hospital of the University of Pennsylvania and also for Children's Hospital of Philadelphia. He came from Connecticut, where he was born. He went to Boston for Harvard Medical School, came down as an intern in 1980 to Philadelphia, and luckily for the Philadelphia community, Dr. Lowe is still here. So I would like to thank you for being with us. It's really an honor and a pleasure to meet you, Dr. Lowe. And I think what our guests would like to know, our audience, would be, how did you get into plastic surgery to begin with? You know, what's your journey, and how did you choose this among all the things that a bright young person like you coming out of medical school could have gone into? Tell us your story.
Well, Nancy, first of all, thank you for inviting me. In actuality, I was going to be an architect growing up because I love to draw. My father, however, is a cardiac surgeon in Connecticut. And when I saw him operate when I was in high school, I said, you know, I just changed my mind. I'm going to be a cardiac surgeon. And so throughout college and med school, that's what I thought I was going to be. It wasn't until 3 years into general surgery training that I met a plastic surgeon at the University of Pennsylvania, Don LaRosa, who inspired me to change my career once again. And he's someone who was an amazing artist, an amazing surgeon, a talented practitioner, and someone who was a wonderful family man. And I said, you know, he's everything I really want to be. And from then on, I switched courses, and I have not looked back. That's
fabulous. So that's the power of mentorship.
Yes, absolutely.
Amazing, amazing. So what did he do precisely that really inspired you? I mean, you coming with this talented background, wanting to be an architect and build buildings, you saw him helping people and building, you know, their bodies in some new way. What exactly did you see that you just said, this is different?
I think what most medical students or young surgeons don't realize is that plastic surgery is largely reconstructive surgery. Most people think all you're doing is augmenting breasts, doing facelifts, doing nose jobs. But in actuality, I would see him take someone who had no nose, who had no breast, and he would take their tissue and reshape it and create something that looked like the missing part. And that was almost like a magic trick. And so we feel like on a daily basis, we perform a little bit of that magic.
That's really very, very good. So tell us, once you got inspired and you did the training, how did that sort of evolve? I mean, what kinds of things do people learn when they're becoming a plastic surgeon?
Well, plastic surgeons are both cosmetic surgeons as well as reconstructive surgeons, and so you will rotate through many different areas of the hospital and rotate with other surgeons and other hospitals, and eventually you come to realize that there are many, many ways to actually do something. One of the nice things about residency training is that you learn that there are maybe 5 different ways to accomplish the same goal. There are many different ways to build a breast after breast cancer. There are many ways to do a rhinoplasty. There are many ways to reconstruct a nose if you're missing a nose. You see patients who have traumatic accidents, and so none of those are exactly the same. And then when it comes to cancer surgery, you see patients who are missing certain parts of their face or body, and you have to devise a plan to reconstruct that missing part.
Very good. So you really work in a team relationship with other surgeons, other parts of the healthcare team.
Absolutely. We pride ourselves in having a multidisciplinary approach. That's where many different doctors will collaborate to take the best possible care of a patient. So I personally don't like the responsibility of having to cure someone's cancer. So I enjoy being the good guy who comes in after someone has removed the cancer and now there's a large defect. And I like restoring that person's form back to normal and trying to restore them to as normal a life as possible.
Very interesting. Well, in terms of the reconstructive part, what is the likelihood of how cases come to you? I mean, some people would come through the door with problems already that you then can devise a plan. But I'm wondering, do you see some of these people coming through the emergency departments? I mean, a trauma case? I mean, what's sort of the mix of cases that you see?
Well, in plastic surgery, one of the reasons we pick it is because there is so much variety. And you will get patients who are referred by your colleagues. Sometimes, if you've been around long enough, you get a bit of a reputation, so you'll get patients who are referred by people who you don't actually know. And then there will be patients who look through Philadelphia Magazine. They'll say, well, who are the top docs? Not always entirely reliable, but if your name's in there, you feel good about it. And so these patients will come. And sometimes you'll even get international consultations where people, based on the reputation of the institution, such as the Children's Hospital, we will get patients who come from all over the world. They don't really necessarily know your name, but they know the reputation of the institution.
Interesting as well. How about in terms of your day? What's a typical day like for a plastic surgeon at the Hospital of the University of Pennsylvania? Well,
we are a training program, so we do have residents. And so as with surgeons in all specialties, you need to round on your patients in the morning, make sure the ones who are in hospital are doing well, and then it's off to the operating room or off to office hours. The nice thing about plastic surgery that's a little bit different from other specialties is that we do a lot of surgery in our office as well. And in cases like general surgery where they might see pre-ops and post-ops and follow them, there are many patients who actually we see for the first time, and then in the office we take care of them. Sometimes it's something very small like a mole removal or cyst removal, but other times we will do more complicated cases. Sometimes they want their eyelids done, sometimes it's liposuction, and sometimes some of the minor cases under local anesthesia can be done in an awake setting in the proper patient. You have to choose your patients carefully and know which ones will tolerate that and which ones won't.
Well, you told me as we were talking about putting this show together that really there's a whole span of people that are involved. I mean, from very young children to the elderly. And since you're on staff at both the Hospital of the University of Pennsylvania and Children's Hospital, what are some of the things, like for instance with children, that you see? I mean, what are some of the trends of what kinds of problems a plastic surgeon would encounter with children?
So problems in children will actually date from infancy all the way up to about 20 years of age. So infants are born with many deformities. Some of the ones people have heard of are, for instance, cleft lips and palates. And you will see advertisements in magazines showing these children who have a large gap in the middle of their lip. And that is something that's devastating, not only to look at, but also functionally. These children cannot breastfeed, they cannot speak normally. And helping a child at that age really helps them for the rest of their life, and that's something that's incredibly gratifying. There are children who are born with hand deformities. I have partners who are experts in congenital inborn hand errors. There are patients who have funny shaped skulls, and I have other partners who are experts at what's known as craniofacial surgery, where they're actually taking the bones of the skull apart and putting them back together after they've reshaped them. That's absolutely fascinating. And then I have other partners who are specialized in facial paralysis when children are born with paralyzed faces and cannot smile. But we also treat children who are victims of accidents, and so there are plenty of children who fall victims to either dog bites or motor vehicle accidents, and those are obviously very devastating, not only for the patient but for their parents. And so that's something that sometimes takes many stages to reconstruct. There are children who are born with deformities of their body. There are, for instance, really girls and boys who are born without chest muscles, so they don't have a breast or they don't have a normally shaped chest. These are obviously psychologically devastating for these kids. And then there are some that start to verge a little bit on the cosmetic. Children who are born with ears that stick out. When they get to about age 6, they get the teasing at school, and that causes a lot of embarrassment, a lot of tears. And so there are operations that may involve something like that. It doesn't really change their hearing, but it changes their confidence and their outlook on life and how they interact with their peers.
Right. Knowing that every case is different, but I'm just thinking about advice to parents in terms of these children cases that you're talking about. Are there things that you would give advice to parents in terms of if they have a child that has any kind of congenital deformity, something they were born with, is it better to do it sooner in general than later, or is every case very different and you would just say, you have to get a consult and each case has to stand on its own merit?
In something like cleft lip, which is something I do a lot of with a couple of my other partners, there are certain general timetables. So for instance, children with a cleft lip will generally get their lip repaired somewhere in the 3 to 6 month age. Our orthodontic colleagues we work very closely with will often help to mold their faces so that makes our operation easier. When it comes to a cleft palate, that's more like a year of age. When it comes to a gap in their gums that we may have to put some bone in there to help reshape that, that's around 6 years of age when their permanent teeth are coming in. So there are general timetables, but not always. Those aren't hard and fast, and sometimes you do have to individualize. When it comes to something like a breast reconstruction on a girl who has not had breast development on one side, that's something that we will delay until the teenage years, obviously, to keep pace with the opposite side. For instance, balloon expanders are something that we use for adult breast reconstruction. We use them also on young girls, where you can put in a balloon expander, inject it periodically over many years to keep pace with the opposite side, and eventually switch it to a permanent implant. When it comes to things like rhinoplasties, generally you want to wait till the nose has stopped growing. That's about age 16 or so you delay it until then. Those ears that stick out, coincidentally, children begin to pick on other children with deformities when they're about 6 years of age. That's when your ears are fully grown, and so that's a good time to do that ear operation. The children are highly motivated to do it, and you're not going to interfere with ear growth at that stage.
Interesting. With how you do have basically clinical guidelines for all of these, so that's good advice for the parents. I mean, so when you have a child or someone that has this problem or someone in your family, really getting that consult and planning, knowing sort of like what the usual time frames would really be helpful in terms of planning something like this. How about the psychosocial aspects, especially again for the children that we're talking about now? Do you see that the children, have a wonderful response to this? How about the parents? I mean, what is the usual outcome? Is this always like a happy event?
Most times it's a happy event, and that's the nice thing about pediatric plastic surgery. There are also going to be children or parents who are not entirely happy with everything you've done for them. And that's one of the things that you never know about something that verges on the cosmetic arena. When you're doing reconstructive surgery, I think parents are almost uniformly happy for what you can offer their children. And it's great to see a child blossom, a child who is very self-conscious, does not interact with their children, and then you do something that helps them. And then you see them back in the office, you can already see an immediate personality change. That's very exciting. But there are always going to be cases where there are going to either be complications, things don't go well the way you expect, and then you have to regroup, come up with a sort of backup plan or alternative options.
In our society, there is so much emphasis on, beauty and conformity, so to speak, that it's good that we have these alternatives, such as your expertise and the expertise of your colleagues to make these things work. But I'm wondering, do you ever come across people who have values that are different, where they don't necessarily think it's so important to be perfect? And therefore, I mean, you may not meet them because of your field, but I'm just wondering if you've come across that in your practice, where people challenge that and basically don't necessarily feel, unless it's a functional change that they must do for breastfeeding with the cleft lip and palate, that they really figure it's okay, it's really not important.
Oh, well, I think everyone should realize that cosmetic surgery is not essential. No one needs cosmetic surgery. They want it, and if it can be done safely, and if the patient has what we call realistic expectations, then certainly it's something that we offer them. But absolutely no one should ever be told that they actually need it. No one should be told, and sometimes parents you can tell when they're coercing their children to undergo an operation. That's when it's important for us to then side with the patient and say, your child's old enough to decide for themselves if they really want their ears operated on. And even though it may be painful for the parent to deal with that, sometimes you have to really be the child's advocate.
Have you run into those cases?
Absolutely. There are parents who will bring in their children when they're 3 years old, their ears stick out. They say, we want you to do this now before they get to school, before anyone teases them. And you say, well, I'm sorry, but first of all, ears are still growing at this age. It's almost better if the child really wants the operation themselves. And something else actually that I meant to mention, when babies are first born and their ears stick out, it actually is possible to mold those ears in the first couple of months of life into a normal shape, and they will actually stiffen and keep that shape. And that's because there are maternal estrogens still circulating in the baby's blood up until about 6 weeks of age. So their ears are actually soft, bendable, and shapeable. But very few people in this country realize that. And then once you're past that golden period,
right, that's the window of opportunity is gone.
Then they stiffen, and then you're looking at surgery that insurance doesn't pay. And it's actually the insurance companies that really make that distinction between something that is simply appearance or something that is actually functional.
Right.
And also they will say, well, if it doesn't improve function, it only improves the way they look. Well, then we don't cover that. That's cosmetic.
Right.
And so we are constantly writing appeal letters trying to explain, well, this scar that this person has, in a sense, is a functional thing. It's on their face. And we always say the function of a face is to look like a face and help you interact with the rest of society. And if you have a scar that detracts from your appearance, or if you have some other deformity, for instance, after cancer, people want to look normal. They want to be able to go out there.
Absolutely.
And so for insurance companies to then say, well, our doctors don't feel that this is really something that's that important because it doesn't really affect how they actually function in terms of maybe their speech or their swallowing or something like that. It's a tough struggle that we deal with every day.
Let's explore that for a moment.
Yeah.
So you write these appeal letters, and it goes, before a board of peers, that work for the insurance companies or paid by the insurance companies. But they really want to also be fair, as professionals. So, they do try to read these things, not just with the dollars in mind, but try to be fair and equitable. But every letter, I'm sure, is a very heart-wrenching appeal. Otherwise, the physician wouldn't really necessarily be writing the letter to begin with. What's your track record, not you personally, but what seems to be the trend in getting a positive reading on that?
Well, I'll give you an example. At Penn, I work very closely with the general surgeons. We have patients who have very big abdominal wall hernias, which means that part of their abdomen is very weak, so their intestines are pushing out. That's a functional problem.
Yes.
Because they can't lift things, they can't be very active. But they tend to also have a lot of stretched skin, and they usually have multiple scars from previous surgery, which is how they actually got these hernias. So we found that what works very well for these patients is that I work in conjunction with the general surgeons. They will fix the hernia, but they would like us to plan the incision, which usually removes a large portion of that extra skin, a large number of their pre-existing scars. So we think that they heal better during the operation. It's much easier for the general surgeons to do the operation because they can see everything. It's a wideness.
So you clear the field, so to speak.
Exactly, and then we come back and close for them, so that they love that too.
Right, then they can move on to the next case.
But I would say maybe 50% of the time insurance companies will say, oh, we understand the hernia part, we'll cover that, but we're not going to pay for this, what we consider to be a cosmetic tummy tuck operation.
Interesting. Do you think that's going to change, though? With healthcare reform, there is going to be sort of a bundled payment. Now, most of that is usually assigned to people from a primary care or an episode of care, which often has to do with hospitalization for diabetes or a cardiac incident. How about for surgical intervention such as this? I haven't really, read about that, so I'm not really sure what the trend line is for that.
Well, I usually tell the patients whatever they don't have to pay for, they won't. And so if anything looks remotely cosmetic, they will usually say, well, we understand why you want to do this, but we don't cover this operation. That's part of our list of operations or procedures that you have to pay out of pocket.
So it may or may not change with the whole reform of payment.
I would think it would be less and less chance that they will actually cover it.
I see. Because they will be even more stringent on
Correct.
that, as they put money into other things that are felt to be, much more life-threatening or things that are really
Absolutely.
much more interventionist. But I hate to take you back, but I was intrigued with the ear molding, especially since you said that in this country it's different than some other countries. So obviously we're missing something. And how is it done? And tell us about your experience with other cultures.
It was actually a Japanese surgeon who was a visiting professor here at Penn in the 1980s who first published an article in our plastic surgery journal. And that's when they realized that you could actually shape these ears in young children. And the general rule of thumb is if you start at 2 weeks, you just have to mold them for about 2 weeks and then they will stiffen. If they're 4 weeks old where the cartilage is already starting to stiffen, you have to mold them for at least 4 weeks. And so my chief, Scott Bartlett, said, this is something we really need to be offering parents, and we really need to be educating our pediatricians about this as well. But it's very, very slow to do that. And we understand. When children are first born, ears are a low priority on their list. There's so many other concerns. But when they come to see us when they're 5 years old and we say, oh, by the way, insurance doesn't cover this, and they say, well, our pediatricians happy to write a letter, and we say, well, no, that's not going to help. And they say, well, our psychologist, because the child's crying at night because the other kids are
Right.
teasing them.
Right.
And we say, they don't care about that either. They say, as long as it doesn't improve their hearing, which it doesn't,
Right.
we're not going to pay for one of these ear operations to set the ear back. And that runs them into many, many thousands of dollars if they're going to do that.
Right.
I've had adult patients who come in and they say, my whole life I hated my ears because they stick out. And I go, well, it's kind of too bad. Your parents didn't realize
Right.
30 years ago you could have done it for free very easily.
Now, all right, so tell us, what's the technique? And
So
is that
there-
something that you can tell us and people can be aware of?
Yes, there are actually now commercially available ear molding systems where they consist really of some plastic framework that you can stick to the side of the head so you don't have to shave your baby's head, which I understand why some parents won't want to do that.
I don't think most some babies do have a lot of hair,
Yeah.
and a lot of them don't have any, so that's not an issue.
And you need to the reason most ears stick out is because most ears lack that natural, what we call that second fold, and so the ear kicks out like that. And so if you bend it back, and parents say, it looks great when we bend it back, but it just springs back that way. And that's because of the memory in the cartilage. But when you're a baby, you don't have that memory, and you can push it back and keep it that way. So whether it's taping.
With this, taping,
Well,
okay.
you can also do it homemade. You can take a little wire and make that little sort of curved shape and bend the ear around it and then put some little paper tapes there and keep it that way. And so, in fact, if you're diligent about it, or if you use some putty or some rubber, so one of those, don't try this at home. In fact, you probably could try this at home and actually get away with it. But if you come to see us early enough, then we show parents how to do it.
I think that's a fascinating part of this discussion because when you think about what parents focus on, as soon as babies are born, moms are counting their fingers and their toes. They're not, again, necessarily, like you said, looking at their ears. But maybe that's something that if we had more public education,
Absolutely.
it would be so simple. I mean, every mother is looking at their baby's face and head. I mean, that's their primary focus as far as their whole maternal bonding experience. So it's not something that is easily missed after the first couple of days.
Correct. In fact, just a couple of weeks ago, one of our secretaries in our office adopted a child, and she brought her in so everyone could see the child, and all of us immediately noticed that one of the ears was a little wrinkled.
That's the problem bringing your baby into the plastic surgeons that you work with. Oh, okay, we can fix this.
And so we all said, between ourselves, well, I don't really want to mention it to her because I don't want to make her self-conscious. But then finally someone did, and she said, well, I noticed it myself too, and I'm bringing her back tomorrow so she can get the molding done. So,
And this is an
yeah.
infant
Yes.
within that window.
Absolutely.
Of
yeah,
how many
yeah.
weeks again?
Well, ideally, you'd like to do it you'd like to start within the first couple of weeks of life. So you do have a short window, but you can do it sometimes for some shapes and some deformities up to several months at least.
Very good. So is this possible to find information on this like by Googling it? Or
Yes.
would there be YouTube demonstrations of how to do this? I mean, how would people really get more information on this?
Well, everything's available on the internet, and so if one were to Google ear molding, it is on there. And you will see different people, and there are many doctors who advertise it as well. And we sometimes use some of the commercially available systems, but I also know that my chief, Scott Bartlett, sometimes goes to Home Depot and gets some extra wire. and
That could be a whole new demonstration at
Yes.
Home Depot, like how to remodel your bathroom. And oh,
Right.
by the
And
way,
your kids'
we're
hair, so-
offering ear molding this
Yes.
weekend.
Yeah.
That is amazing. I think that's really an interesting outcome of our discussion. I have not heard of that. So it's news to me, but I'm not into pediatrics, so
Right.
it's not something that I would necessarily
Right.
know about. But I think that having been in maternal and child nursing years ago, just knowing that this is available, and again, it's be so simple for nurses who are working in those fields, you know, in labor and delivery and postpartum, you know, even though the lengths of stay are very short in this day and age, it's certainly enough to even make mention of it. They may not do anything right then and there in the first few days of life, because as you said, sometimes in the first couple of days, things sort of flatten out.
Sure.
Anyway, you know, as part of just coming, you know, into life and sort of getting stabilized for the first couple of days or a week. But after that, it would be noticeable, and then there would be, you know, this immediate intervention that could really solve a lot of problems down the road.
Another thing that we see a lot of in pediatric plastics and also pediatric dermatology are something called hemangiomas. Hemangiomas are little benign blood vessel clusters that are the absolute most common benign growth that babies get in the first year of life. Pediatricians historically have advised parents, don't worry, they grow for maybe 6 to 12 months and then they start to shrink, and they generally disappear by age 5. So they say, you know, all you have to do is just wait till age 5 and you'll do fine. And that is true for maybe 3/4 of the patients, but the other 25 to 30% do not shrink well, and they have significant deformity. So what has changed now, one is the internet. Parents are looking up everything, and now they realize you don't have to simply sit back and try to be patient. You can be proactive. There are medications available that will actually stop the growth of these hemangiomas and may prevent permanent deformity down the road. And so we work very closely with our dermatology colleagues, and when we see babies who look like they have a facial hemangioma that could cause significant deformity, we get on the line with our derm colleagues, and they say, oh yeah, we'll see them in 1 or 2 days, and they discuss with them what medications and options are available. Sometimes we don't do anything. Sometimes it's a cream that you put on. Sometimes it used to be steroids, which parents never really liked, but now there's something else. A drug called a beta blocker, which has been known for decades as a heart medicine, was just found recently, actually 2008 in France, that actually it also suppresses the growth of these hemangiomas, and that has now become at the Children's Hospital the #1 treatment to stop these from growing. So pediatricians are pretty much on board with that. They've
Right,
kept up with
right.
that literature, and now I think they've all started to shift. We need to do it for something
Right.
like
But that's
yours.
a very good example of
Yeah.
this partnership. You know, people coming, looking at the same problem, but having, you know, two different inputs and really finding a much, you know, better solution together. Well, David, you have been amazing. I'm sure that everybody that's watching this show is now going to be looking at every newborn differently. And I think that if there was stock in ear molding equipment, this would be the time to go out and start making those investments, because I love the idea that with your talent and expertise, the idea that that was a best practice that could be adopted. It really has almost like a public health application because there's so many things that happen if you're born with. You really can't do anything about it using just your own home remedies or something simple. You really do need medical expertise. But I think that in addition to telling us about your fascinating career and your work life, which sounds like it's always challenging, every day is different, that you've really imparted something very useful in your discussion with us today, and I want to thank you. I have a last question. Did you ever regret not becoming an architect?
I guess I would say there are some days, actually some nights in particular, where you're in the hospital, it's 2 in the morning, and you start to wonder, maybe I made a mistake, but no, this is a fantastic job, and every day I am thankful that I can do this. It's a great life to be able to have the privilege to actually treat people. Anytime you make an incision and you're dissecting through anatomy, you go, boy, this is the best job in the world, because who else gets to do something this amazing, to actually explore a human body on a daily basis.
Right. Well, I think that you've learned how to take your love and passion for making something different, something beautiful, and you've applied it instead of your early ideas of buildings to people. And I think that we're very thankful for you. I'm sure that your patients are also very thankful that you made that choice. And again, I want to thank you so much for being with us today. David Lowe, Hospital of the University of Pennsylvania, thank you so much for being with us. Have a wonderful day. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening, and join us again. And remember, with health, all things are possible.